I unmuted, yep. Bobby has pointed out several times the most common thing said on Zoom is you're on mute. So I am going to move through this pretty quickly. Bobby was very gracious in her introduction, but privately she sent me a message saying people are tired of hearing from you, so just go through it quickly and get this done. So that's our relationship. But going through this quickly, because I do want to make sure that we have enough time on the other side of this, so that we can begin the presentation. I have tacked my email towards the end of this, and after I did that, it occurred to me that Kara, I need to send that to you as an update. So it'll be in the slides. If there are questions on this that I'm going to move through quickly, and you have them afterwards, you're welcome to email me, and I will get back to you within 48 hours. I won't say the same day, but within 48 hours. So today we're gonna wrap up March's didactic presentations about substance use, talking about issues related to youth substance use in more general terms. And the direction I'm going to go today is I'm going to start out by talking about some potential risk factors that maybe we can identify from the outside. Maybe some more enduring internal factors that might contribute to building the risk factors for youth substance use, and then jump into some statistics and some numbers about the prevalence of youth substance use, just to increase awareness of some of the things that we should be looking for. I'm going to move through this pretty quickly, and like I said, if you have any questions about this afterwards, I'll be happy to have a discussion on the outside with you about that. So, possible risk factors, and something that we see here in ECHO quite a bit, is an involved history of trauma, and especially the early childhood trauma with developmental trauma, other ways to frame that, unmet developmental needs, abuse early on of different kinds, and beyond that, beyond the developmental trauma expectations, also current experiences of trauma. I think one kind of predicts the other, and back and forth. And certainly it does become very integrated with substance use and mental health, reactivity and acting out. And you know, on this ECHO, if you're familiar with youth with multi-system involvements and needs across the different areas, this is not something that's unusual or groundbreaking. But certainly any time that we see a history, especially of developmental trauma, and we can even think, you know, prior to that, with any kind of prenatal exposure or trauma, that we would have an expectation that we really should be looking for substance use in the youth that we're serving or working with. Family history, very, very strong influence, whether that's genetic. We're not going to move into it today, but you can have some of the genetic proclivities, and then with some epigenetic influences moving in the direction towards or moving in the direction in a protective fashion in both directions. Family history of use, not just the genetic influence, but family history of use. Is it something that the kid has been around? Is it something that they have been exposed to, either, you know, overtly, covertly? Family acceptance of use is something that we see a lot in the programs that I work with, that you know, as long as they're not doing heroin and they're just smoking weed and cigarettes and drinking, that's kind of an expectation. You know, that family acceptance of use certainly is a big key, a big risk factor. And we can talk about social learning, whether that's from family, from peers. We can talk about social media exposures, things like that. These are risk factors. Prenatal exposure, mentioned that. Low parental supervision or involvement is a really big risk factor. Family rejection of sexual or gender identity. We've heard about a couple of cases involving that. Haven't necessarily crossed over into the substance use, but this is one of those areas of risk that we really do want to key into. And then just with the recognition of risk factors, then include some screening questions and include some screening on a regular basis with the youth that we're working with when we see these risk factors. Peers and friends who are known to use, that's a pretty big risk factor. Lack of school connectedness, low academic achievement, and justice and legal involvement are also very big risk factors. Tacked in here, something that just came out, one of our colleagues at CIP clued me into this, from the health policy fact sheet about the impact the pandemic is having, or the expectations around that on ACEs as they're impacting youth and families. This is not directly keyed into youth substance use, but it is very much so about ACEs and the impact of that. And so I think it's a really useful resource. Some other areas of vulnerability that could lead into risk factors, that could build risk factors. With the recognition that adolescence is a period during which mental health and substance use needs often very first appear, that we become, that we recognize that these are there. A lot of times the basis for the mental health needs were there first, and typically mental health needs will precede the onset of substance use needs, whether it's problematic use, experimental use, moving in the direction of problematic, typically, not always, but typically. And then there's always the question, does one cause the next, and how do we treat those? And I think last week we talked about some treatment considerations. Simultaneous integrated treatment is our best approach. Do both areas of need follow a similar neural vulnerability pathway, which is a newer way of thinking about this? And some of the thoughts or the hypotheses in this area are really interesting. And there's areas of research in the resource section here that can expand this if you're interested in it. That possibly we have built within us vulnerabilities that make us more vulnerable to develop certain types of mental health illnesses or needs, then that can be matched to an increased vulnerability to certain types of substances, not just substance use in general, but certain types of substances. So not a lot known about that, and I don't know how predictive it is, but it's an interesting line. So substance use typically begins during adolescence. This is happening during a normal period of imbalanced reward sensitivity, increased sensation, and novelty seeking. So wrapped within all of the concerns that we talk about with the risk factors and what's going on mental health wise, and maybe some of the other multi-system involvements, is the acknowledgement, the recognition that adolescents are adolescents, and this is a time of life that is marked by some lability in general, and so understanding it within that framework is important. And I'm going to skip over the next part with some of the brain development areas. The one resource cited here at the bottom, this Squalia and Cervenka, an interesting meta review paper came out in 2017 that goes through a lot of the bioneuro research and the current aspects of that. So if this is something that really interests you on the vulnerability side of things, not necessarily the behavioral risk factor, but some of the earlier vulnerabilities, I would recommend that paper to take a look at. So other vulnerabilities, things that we recognize quite a bit: persistent irritability, anger, lability. So, and this is beyond the normal expectation for adolescents, because there is an expectation that teenagers, adolescents are going to have periods of irritability, and upset and some mood instability from an adult perspective, not from an adolescent perspective, but from adult perspective. So this is beyond any kind of expectation that we would see in an adolescent. When it stands out beyond that, then this is a hallmark of behaviors and things that we recognize in adolescence that do clue us in that substance use is a very possible addition to the needs. So, and related to that, emotional and behavioral discontrol identified before adolescence in early childhood, and I think that this is things that we recognize when we work with the younger ones and moving into adolescence, that behavioral discontrol, that dysregulated affect early on does predict a lot of future things, which includes substance use. Some very common co-occurring diagnoses, and then I'm going to jump into this last part and wrap up pretty quickly. So on the mental health side, and this is coming from like a decade of CSAT programs that were working with adolescents, and they just identified the most common areas of on the mental health diagnostic side that were involved when adolescents were receiving treatment on the substance use side. Not unexpected, conduct disorder, and I think that they combined ODD and CD in that. The conduct disorder led the way, which is descriptive, not necessarily all that ideologically telling, right, in terms of what's actually going on, but it is descriptive. So behaviorally descriptive. ADHD very commonly, and again, I think that that's one of those descriptive areas. A lot of really good research showing that effective treatment for ADHD takes a youth into just a normal risk category. For substance use, it doesn't increase any risk for substance use. Won't get into that. Depressive disorders are really a big hallmark, and it's also the most common area of truly disruptive mental health needs in adolescents. PTSD, and it's hard to actually cross the threshold into PTSD, and there's no diagnosis for developmental trauma. So other areas that we would look for in terms on the mental health side. Some stuff about depression, how common it is in adolescents. I'm going to encourage all of you to take a look at this, and then I'm going to move through very quickly. What time is it? Yeah. I'm just going to wrap up the prevalence stuff in a couple of minutes. It is all here so that you can refer back to it. Three areas that have really good prevalence measures. Some of them are focused in different directions. There's monitoring the future that comes out every year, prevalence, and really can track trends in youth substance use. There's the NSDUH from SAMHSA. This takes a look at age 12 up, focused on some risk behaviors, mostly drugs and alcohol and depression. And then the CDC puts out the youth risk behavior surveillance. And the CDC is looking for what are the really risky things that we do, and what leads to death. And so it has that frame in terms of looking at risky behavior. So 3 different surveys, 3 slightly different takes on drug and alcohol use and risky behaviors by teenagers. Really, really good resources. The most commonly used substances. Things that we would expect to see in adolescence. And I think it goes in a little bit different order than, maybe we have our general expectation. The most common is not cannabis. And as a matter of fact, it is probably 3rd most common. Depends on how you measure it, could be 2nd. But in the last year, alcohol is far and away, without even a close 2nd comparison, the most commonly used psychoactive substance by adolescents, both it measured, if we measure lifetime use in the last 12 months, in the last 30 days, in the last 2 weeks. Alcohol is at the top of that list. Vaping has taken over 2nd place from cannabis, and certainly vaping use is on the rise, and a lot of concerns about that. It's a little bit cheating to put it in at number 2, and the surveys didn't necessarily, I did, because vaping captures just plain flavors, nicotine, and cannabis. So in that way, we could say cannabis is number 2. So I'm not going to go through these numbers. Alcohol, binge drinking is our really big concern with adolescents and alcohol, in terms of an already impulsive cohort or group of folks, already impulsive and leaning more towards approach rather than inhibition side of things. Alcohol just really increases that. And so alcohol use is at fairly low levels compared over the last 40 years, but still, when we look at measured in the last 2 weeks, 5 or more drinks on a single occasion, high school seniors, almost 17% in the last 2 weeks. So they're at lower levels than they have been in a while. It's still a lot of kids binge drinking on a pretty regular basis. So some numbers about vaping, and then cannabis. If you want to take a look at this, these slides are available to you. Others have mentioned, it is worth mentioning, opioid use is at the lowest level ever measured for adolescents, which is not to say they're not at risk from opioids. The risk really is the family risk and what that does systemically in terms of the impact. Youth are not in general using opioids. When they do, there's a incredibly high risk there, and it's not saying that it's 0, but it is pretty low. So that was where I was going to stop, and it is where I'm going to stop. I did include in here something we put together at CIP that just compares those 3 prevalence surveys that I talked about side by side with some different areas of comparison where you can take a look, and it just makes it easier instead of going through 400 pages of the surveys. So they will be here and posted on the website, and Kara will email those out, or a link to them. And with that, Bobby, I am going to turn it over to you. So a lot of fast talking and